It is so wonderful to be here today at AHA Epidemiology, Lifestyle 2026 with my good friend and colleague, Dr. Sadiya S, who is the Magister Professor of Cardiovascular Epidemiology and Associate Professor of Medicine and Epidemiology at Northwestern University. She's going to be giving the William Kannel Lectureship in Preventive Cardiology, and we're really excited to hear her perspectives on preventive cardiology today. Sadiya, it's wonderful to have you.
Thank you, Chiadi. It's really a great honor and an incredible privilege to be here and be selected for the Kannel Lecture.
Well, let's actually just take a step back for a moment and talk about William Kannel. And, obviously he was somebody who has had a tremendous impact on how we think about risk-based prevention and obviously the work you do today. Tell us a little bit about how his work has influenced what you're doing.
I think in part because Dr. Kannel really is the grandfather of preventive cardiology and of the field that we practice today. This is such an incredible honor. He really coined the term risk factor by being one of the first directors of the Framingham heart study. He transformed the paradigm of waiting until heart disease happened and thinking that it was inevitable into something that was predictable and preventable. And the work that he led really laid the foundation for risk prediction, the prevent equations, and the work that we do today.
No, well, I think it's a fitting homage to his work that you're going to be speaking tomorrow. And obviously over the last couple of years, we've had some evolutions in terms of risk from the multiple Framingham risk equations to the pooled cohort equations and now to the prevent equations. So maybe you can just briefly speak about some of the rationale for the more recent evolution to prevent and how some of those updates are enhancing our approaches to risk prediction.
Yeah. First of all, the prevent equations really build on the Framingham heart first equations. They really laid the foundation for multivariable risk prediction, thinking about multiple risk factors influencing and being able to then predict risk for heart disease to be able to prevent heart disease. As the pooled cohort equations built on the Framingham heart equations, they brought in more cohorts, they brought in more people, but they were still pretty limited by using just observational cohort data. And so one of the biggest advances in the prevent equations was the ability to not only pool observational cohort data, but also incorporate electronic medical record data to get us to a sample size of over 3 million for the development and 3 million for the validation. And I think in part, that is a key advance to be able to have equations that are largely generalizable across populations for starting the risk assessment process.
Yeah, so obviously tremendous evolution and real world implications for the way we're doing prevention today. Another important change over time has been that we've started with a substantial focus on cholesterol and on statin therapy, and that was initially obviously what many of our risk equations were geared towards informing, but our armamentarium of preventive therapies has dramatically expanded over time, and now we have this broader concept of CKM health and various preventive therapies related to that. Could you tell us a little bit more about how the prevent equations have the potential to inform that broader slate of preventive therapies?
Yeah, it's a great point. I think two things have happened, right? We have more therapies that we now know that can prevent atherosclerotic cardiovascular disease like statins did, but beyond that, and medicines that can prevent heart failure. The other thing that's happened is we have growing evidence and data to support that kidney disease and metabolic disease, as you point out, cardiovascular kidney metabolic syndrome broadly, is a key phenotype or driver of cardiovascular events. So if we really want to prevent heart disease today, we have to be able to incorporate kidney disease and metabolic disease in our prediction and in our treatment. And so I think those things have been really important. So now, as we think about those things in developing the equation, we're at the point now where we're thinking about how do we use the equations to also inform the treatment. And that's where I think there's a lot more opportunity that we still have left to discover. So are there prevent equation risk thresholds that can help us understand which CKM therapy somebody should get if they're at higher risk for heart failure, or their total cardiovascular disease risk is higher? And we've seen some of that in blood pressure and the dyslipidemia guideline play out, but the CKM guideline, I think that's coming, will really help inform some of these questions.
That's really helpful. I think the other very important epidemiologic trend has been the fact that we are recognizing that risk and cardiovascular events are emerging earlier and earlier. And of course, prevent shifted to including individuals age 30 and above versus 40 and above for the pooled cohort equations. And as part of that, there's been this focus not only on 10-year, but also on 30-year risk. So I'd love to hear your thoughts about how we might start to think about incorporating that 30-year risk horizon in our kind of decision making, or at least in our interpretation of risk, and also about how we might communicate that risk to that younger adult population.
You hit the nail on the head. It sounds like a great idea to predict risk over a longer time span. Of course, we don't want to just prevent heart disease over the next 10 years. We want to prevent it over the next 30 years. But when you sit down with a patient and you start to have that conversation, it becomes really hard to say, what does it mean that your risk over the next 30 years is 10% or 15%? And that's where we've really done some work in trying to understand, can percentiles really help translate some of that? So we're all used to percentiles for our kids' growth curves or for standardized tests. And here, the percentile tells you where your heart disease risk is or your prevent risk is relative to other people your age. And that can sometimes be a little bit more motivating or help to understand or resonate where your risk stands.
Yeah, that's really helpful. I mean, we're going to have to think about how we best communicate this, and the goal here is to motivate change, whether it's lifestyle measures or pharmacologic therapy. So that's really helpful to be thinking about that. Risk prediction is obviously super important, and the prevent equations have done a wonderful job of discriminating risk and have also been helpful for correcting some of that overestimation of risk we were seeing previously with the pooled chord equations in this more contemporary population in which it was developed and validated. But then as we take that from the population level to the individual and try to, characterize risk for the person in front of you, can you tell us about how we may start to think about how we can complement that risk prediction with other personalizing approaches to really make sure we're giving that person in front of them the picture that best matters for them?
That's such an important point. Risk prediction equations, like the prevent equations, are really a first step. They're to get you started to say this is about where you're starting for your risk. And then we want to think about what are other risk-enhancing factors. For example, there are risk enhancers for atherosclerotic disease, there are risk enhancers for CKM syndrome, and are there other tests, whether those be biomarkers like Lp(a) or tests like coronary artery calcium, that may be helpful to understand whether or not somebody needs a medication to help them lower their risk, in addition to lifestyle changes, which should always be the first step.
First of all, an honor to have you here. Exciting to have you bring that perspective to the attendees here at AHA Epi Lifestyle. And we're really grateful for the work that you're doing generally. So thank you for spending your time with us today.
Thank you. It's really an incredible honor to follow this legacy, in addition to be able to share some of this work today.